respected Shankar sir, the chairperson for the day, and respected Shadi Thomas sir, the speaker for the day. And we have a wonderful topic for today. That is T21, Justice Delayed is Justice Denied, as a part of World Down Syndrome Day. And as you all know that we are doing our Tuesday series meticulously under the leadership of our state president, Joe sir, and our state and our Trivandrum president, Dr. Rukmani K, which is useful for all practicing pediatricians and for PDs. And without further delay, I would like to hand over the mic to Rukmani madam. Over to Rukmani madam.
Good evening, respected State President Joseph, respected Speaker of the Day, Dr. Shadi Thomas Johnson, and Chair of the Day, Dr. Shankar, and all other colleagues and teachers, and Dr. Beno, our Secretary. As Dr. Beno said, this is the 34th Tuesday series of IAP Trivandrum, and we have taken this topic today because you all know we observed World Down Syndrome Day on 21st, and the topic today is Trisomy 21, Justice Delayed is Justice Denied. The topic is very relevant. As you all know, let us all stand together with those children who are having problem with the chromosome 21. Let us be with them, not away from them. Let us not consider them as separate from us. Let us be together with them. So with this small introduction, I invite Joseph to give a address to the audience.
Thank you, Rukmani Madam, the President of IAP Trivandrum Branch, and Secretary Dr. Beno. And today the speaker, the doyens in the field of Down Syndrome Support Group, Dr. Shadi Thomas sir, our past State President of IAP Kerala, our Vice President of IAP Kerala and Senior Genetics of IAP Kerala, Dr. Shankar, Professor of Pediatrics, Government Medical College, Trivandrum, and all the faculties joined together and the delegates, dear IAPians. First of all, I take the opportunity to congratulate IAP Trivandrum teams, doing a wonderful job every Tuesday series. The right topic, their selections under leadership of Dr. Rukmani and Dr. Beno, and doing the right topic in the right time for the benefit of the IAP members, OSA students, and dear members. And IAP Trivandrum branch is concerned, they are doing a lot of academics. Along with academics, they are doing a lot of social committed works. In connection with the Epilepsy Awareness Days, they have done a wonderful job along with the IAP Neurology Chapter and IAP Trivandrum branch, and all the members of Trivandrum branch doing a wonderful job for the benefit of the community is concerned. Today, they are selected a right topic. As you know, March 21st, we are all celebrating our branch with a Down Syndrome Day celebrations with the awareness of the public. Still, we know, even though Down syndrome is one of the genetic syndrome in our community is concerned, still there is a lot of dilemmas and myths and facts about the Down syndrome still exist in the communities, and there is a dilemma how to follow up the child, how to deny, as already the theme is mentioned, the denial is an important thread for the Down syndrome children is concerned. So to talk on this topic, we got a very important two persons here there. One is a chairperson, very important person, the genetics for the SAT Trivandrum. He is known for genetic disorder for all the symptoms, and he is a well-known academician for today. And to talk on the scientific part, none other than our past president of IAP Kerala and Down Syndrome Support Group, International Support Group person, Dr. Shadi Thomas sir. So talk and with the chairperson's remarks, I think we all enlightening all the doubt and clearance dilemmas about the Down syndrome management and caretaking issues are concerned. And with this phase, I take the opportunity to congratulate Trivandrum once again and take this, I think this program will be beneficial for all the members. Jai Hind, Jai AP. Thank you.
Now let me introduce the chairperson of the day, Dr. Shankar V.S. He is the additional professor of pediatrics in Department of Pediatrics, Government Medical College, Trivandrum. And actually, he doesn't need an introduction to the crowd today, but still, he is involved in Genesis, and he is the one who holds an MD degree in genetics. And when we all treat common pneumonias and diarrheas, he picks up all the rare diseases from among these children and treats them. And with his efforts only, we in Trivandrum started to do genetic analysis for all the syndromes, and we all received great help from him in dealing with the genetics and also the rare diseases. And I thank Dr. Shankar for that. Now let me introduce the speaker, Dr. Shadi Thomas John. The only word I can very well say in the beginning itself is he is the very apt person and the only apt person in Kerala to deal with Down syndrome. This thought only made me to contact him for the class. There is nobody else whom I could contact, whom I thought was above him to discuss about Down syndrome. That is a simple explanation why he was called for this topic. And let me introduce his profile. He is Chief of Pediatrics and Clinical Support Services, Baby Memorial Hospital, Calicut. He is the past State President, IAP, National President, past National President, Adolescent Health Academy, IAP. And now very important credentials. He is the founder, chairperson of Down Syndrome Trust. He is the patron of Kerala Down Syndrome Federation. And he was a chairperson of Asia Pacific Down Syndrome Federation 2016, and also in the research committee in 2015 and 16. So no wonder he was given the Best Doctor Award by Kerala State 2018. Sir, I invite you and welcome you for the talk. Handing over the mic to Dr. Shankar to carry on with the scientific session. Dr. Shankar, please.
Thank you, Dr. Rukmani, President, Trivandrum Branch IAP. Respected Dr. Jose, President IAP Kerala. Shaji Thomas John is going to deliver a talk on Down syndrome. Dr. Beno, Secretary IAP, and other fellow IAPians who have joined. And I think more people will join by time. And actually, Down syndrome is an important thing a pediatrician should always aware, because it is one of the commonest condition already previous people have told. You are going to see in your day-to-day life. And you should be able to counsel those people, and you should be able to help the families to help them to have a normal stream, inclusiveness in the community. And when we see to talk about this topic, as already described, Shaji Thomas John is the apt person, because I have fortune to have with him in various international arena of Down syndrome meetings, and he's having an excellent passion to work for Down syndrome, children with Down syndrome. So naturally, he is the apt person to talk on the T21, justice delayed is justice denied. Moreover, recently IAP has come up with a management guidelines for children with Down syndrome, and I was also part of it. But Shaji sir is the key person who has taken initiative and interest, and he is the lead author of that guideline. So over to you, Shaji sir, to enlighten us regarding children with Down syndrome, their problem, and how to give them justice. Over to you, sir.
Thank you very much, Dr. Shankar. Can I share the screen? Okay. Okay, thank you very much. The topic, as already mentioned, is Trisomy 21, justice delayed is justice denied. I think, yeah. This is case number 1. The case of baby Doe, which many of you would probably be knowing, or at least heard about it. It was in 1982 in the US, a baby was born with Down syndrome. Born on April 9th, the baby had esophageal atresia. The controversy was to operate or not to operate. The pediatric surgeons were prepared to operate, but the parents and the gynecologist was not willing. The case was then prepared for presentation to the US Supreme Court, and Justice John Paul Stephen. Unfortunately, before the case could be heard, baby Doe died of dehydration and pneumonia at 6 days of age on April 15, because before the law could say something, the baby died. The next is a case of baby B, again a newborn with Down syndrome who had intestinal obstruction, which would have been fatal unless treated. It was probable that if the operation was carried out, her life expectancy would be 20 to 30 years, because that is the life expectancy in those days. Her parents refused to consent to the operation, being certain that it would be in the interest of the child to allow her to die rather than to live physically and mentally handicapped. But the doctor contacted the local authority, who made the baby a ward of court, and asked the court to authorize the operation. Though the court authorized this, the attending surgeon, who respected the wishes of the parents, declined to carry it out. And so the local authority again went back to the court. Now, this is a decision. While great weight ought to be given to the views of the parents, they are not the views which must necessarily prevail. The duty of the court is to decide whether it is in the interest of the child and whether to allow an operation to take place, which may result in the child living for 20 to 30 years as a mongoloid, because that was the term used then, or whether to terminate the life of a mongoloid child because she also had an intestinal complaint. Faced with that, I have no doubt it's the duty of the court to decide that the child must live. So there are so many cases like this where the court had to intervene to get something done, and whenever there was a delay, there was a death of the child. Now, I'll be talking briefly on what is Down syndrome, its history, diagnosis, associated conditions, the general management, the follow-up and the recommendations, and the future. You all know Down syndrome is named after Dr. John Langton Hayden Down, an English physician. This was the paper which he published, Observations on an Ethnic Classification of Idiots. That is what he mentioned, which is published in 1866. Now, coming to the history, the first description was made in 1838 by Jean-Etienne Dominique Esquerel, and later by Edward Segun, much before Down brought in the publication. So that goes to prove that publish or perish, because had they published their observation, probably it would have been Esquerel syndrome or Segun syndrome. The chromosomal aberration was discovered much later in 1959 by the French human genetist Jerome Jean-Louis Marie Lejeune. Coming to the nomenclature, initially it was called as Mongolism. We all know about that. But that was abandoned in 1965 and it is not to be used at all. Other names that came were Morbus, Langdon Down, Morbus Down. Morbus means disease, Langdon Down disease, Down syndrome with an apostrophe S. Later, the Americans deleted the S, stating that Dr. Down did not have the disease. So you cannot call it as Down syndrome. It can only be Down syndrome. And another name was congenital acromicria syndrome, but the accepted term is trisomy 21. And it is better that we all stick on to this term, especially in the medical profession, as trisomy 21. Certain usages, let me go through that. It should be mentioned that children with trisomy 21 and not Down syndrome children, or it should be children with Down syndrome and not Down syndrome children or trisomy 21 children, because the children are the important aspect, not the disease or the condition. It is a condition and not a disease. This is something which is a common mistake that is being made. Even in the last Down syndrome, World Down Syndrome Day celebrations, many of the newspapers tell us Down syndrome badicha. It is not a bada. And the disease, it was mentioned. So this is something which you got to properly. It is not a disease. Children with Down syndrome can have a lot of diseases, but it is just a condition. Now you all know about chromosome 21. I'm not going into details. The smallest human autosome with 48 million nucleotides. There are more than 400 genes on chromosome 21, out of which it is believed that it is 150 to 300 genes that create all these problems, the duplication of these genes that create all these problems. So we have the three types. Trisomy 21, you have the non-disjunction type. We have an extra pair, extra number, translocation, where a part of it goes on to another chromosome. Usually it's 14. The commonest one is 14-21 translocation. And the mosaics, where some are normal and some have abnormal cells. All the photographs that I show are people with Down syndrome. This was a magician with Down syndrome. Now, coming to the diagnosis, we have the antenatal diagnosis, or we have the screening test. We have the first trimester and the second trimester screening. First trimester between 11 and 13 weeks, which is the one that has to be done because it is more reliable, and you get time once the diagnosis is made. The second trimester screening is between 15 to 22. And now we have the NIPT, that is a non-invasive prenatal testing, where the cell-free DNA are checked and they are, the diagnosis is, the screening is as accurate as 99%. It is done after 10 weeks. But for confirmation, you are either going to do a chorionic sampling between 11 and 13 weeks, or if it is later on, you have to go in for an amniocentesis after 16 weeks. Karyotyping has to be done to confirm it. FISH, as you all know, it gives a quicker result, but this doesn't differentiate between the various types. Microarray may be more accurate, but then it's costlier, and it may pick up with unwanted things also, which may confuse you, or the Q of PCR. After birth, the diagnosis is by Gestalt. Gestalt means you look at the person, and look at the baby, you look at the child, and say it is a case of Down syndrome. There are a lot of syndromes. You can just look at them and say, okay, this is so, just by the looks. There are more than 100 variations or aspects of physical findings in a baby with Down syndrome, but it is just one look that gives it. So this is a diagnosis by Gestalt, but then you have to karyotype to confirm it. The confirmation is by cytogenic analysis. The question is it needed? When you can, an expert pediatrician can just look at the child and say it's a case of Down syndrome, why do you want to do it? It's most important is confirmation. The second one is it's essential to know the type, whether it's a non-distinction, it's a translocation, or a mosaic. Now, translocation Down syndrome, they should have the parents checked, for the risk is very high in future pregnancies, unless it's a de novo translocation. And once you have the parents, only then you can predict or you can counsel them what is the risk factor after that and what is to be done. That again is dependent on the type of translocation and the sex of the carrier parent. A female carrier would have a higher risk than the male carrier. About 10 to 15% risk is there, but the male, it's only about 1%. And then 21-21 translocation is supposed to carry an almost 100% risk in the subsequent pregnancies. Mosaics, though phenotypically similar, have a better outcome. depending on the percentage of trisomy 21 cells and the site of involvement, because each organ may have a different things. What you get is from the blood, where they say normal cells are 40 and cells with trisomy 21 are 60, but that is from the blood. But different organs may have different combinations or percentages, and with that, the variation can be the intelligence can be better if the more of normal cells are seen in the brain. Now, coming to the associated conditions, I'll briefly run through them. If you have a cardiac problem in 40 to 60%, our study which we published, we had about 59% cases with cardiac problem, thyroid in 24 to 50, hearing problem in 50%, you have an eye problem maybe immediately or later on in 60%, and many of them have defective vision. Hematological, we have 5 to 30%, and GIT, renal, dermatological, dental, orthopedic, you have almost all the systems involved. But it is, when you say it is involved, it is not that all children with Down syndrome have all these things. They have a higher risk than the normal population. So that is why what I mentioned is the percentage that is given bracket. Now, general management, counseling, as the most important thing. How do you counsel? This is something which we people, we doctors are not trained, and we have made a lot of blunders also. So how do we do it? When do we do it? By whom? And to whom? So to whom, it should always be to the parents. Both the husband and wife should be there. But very often the husbands, at least in my area, they are in the Middle East and sometimes they come pretty late. But in all such cases, the mother should be counseled along with the mother's relatives or the parents of the mothers. Very often what we have seen is that the parents are counseled. They will say, oh, we will tell the mother later on, and ultimately it doesn't happen because they wait for the right time, and that right time never happens. They don't want to disappoint the mother by saying that. But if that gets delayed, the early interventional program gets delayed. By whom? Definitely the pediatrician or the neonatologist, and the gynecologist can also be involved, because the preceding 9 months, the gynecologist was looking after the child. When at birth immediately, and as soon as the confirmation and other tests are being done. Why I mentioned at birth is there have been instances where the counseling is not proper at birth, and then a proper intervention gets delayed. Recently, I had a child who was seen, or a baby who was seen by the neonatologist, advised to come and meet me after the child gets discharged, because I will be able to talk more about the child's condition. And they came to me after 1 year. I asked them why, what happened to the 1 year? No, we thought the child was normal. Only now the child has not started walking. So then we remembered what the neonatologist said. Here, the impression given was there is a slight delay. You gradually go and meet, at your time, you go and meet Dr. Shahji. So you already lost 1 year of early intervention. How? The parents should be relaxed. They should be seated. The doctor should also have enough time with him to counsel. There should not be any disturbance. It's preferable to keep the mobile phone in the switch off position, because we don't want an interference during the time. This is a time when we have to properly counsel the parents. Tell them of the positive signs first. Okay, we done an echo. Your child does not have a heart disease. That is very good. There's no thyroid problem, but we have certain other things. So tell us the positive things first, and okay. Now the counseling should be by a combined approach, a multidisciplinary. You should have a pediatrician or the physician if it's an older child, because all the systems are involved. You have the ENT surgeon, ophthalmologist, cardiologist, orthopedician, dental, geneticist, and a genetic counselor. Initially, for the counseling, you don't have to have all these people there, but then you should get the opinion with all these people, and they should be involved in the management as and when required. And as far as the therapies are concerned, you should have a developmental therapist, a physical therapist, occupational therapist, speech, behavior. A clinical psychologist is very important, because The parents have to be counseled because it's a sort of a whatever it is, it's a shock to the parents to know that they have a child who is not at par with a normal child. So they have to be supported, especially the mother have to be supported. And the children also, when they grow up, they need support. A social worker and a support group. It's always best to have a support group because the support given by the support group cannot be compared with whatever we give as doctors or medical professionals. Now, where do you begin? On first contact, on day 1, but not later than 3 months. Early diagnosis and early intervention, the mother should be the first therapist. The mother should be trained. Mother should be taught what is to be done. How do you give a physical therapy? How do you give a whatever thing is, that has to be taught to the mother because the therapist cannot do much in the early days, but follow-up of the child should be there. Speech and language, very important because there's a delay in the speech. Somebody has to keep on speaking to the child. Stimulation, speech stimulation is very important. Either read, sing, and orofacial exercises are again important because of the small maxilla and tongue, it's difficult to bend the tongue. So exercises are very important so that the speech is clear when the child starts talking. Schooling is what everybody asks about. Intense stimulation at the home till 3 years. You can have flashcards. You can have any form of a stimulation program along with the various items that are now available. School, when I say school, it means a play school or an Anganwadi or a training by a special teacher from between 3 to 5 years. The government has come up with a new policy of having a 15-year pattern where you start the first standard only by 7 years. Till then you have the LKG and the UKG. But here you got to see that the child, he is properly trained because the special teacher is capable of training it better. But it may be preferable not to send to a special school because I had a lot of problems with that because it is just a play center for them where a lot of children who are greatly intellectually depressed. A normal school by 8 to 10 years because by the time the child is able to grasp at least something what is told in the class. A vocational training because they are all trainable and support by 15 to 17 years. After 20, they are on their own. Many of our children are working on their own. Examples of therapy rooms. Now, school-based therapies, there can be music therapies, very important. Dr. Frank Robertson, as mentioned, he's from Israel. He was into this. He said that whenever there's a problem with the brain, the last door to be shut in the brain is the music door. That means if everything else is closed, you can still enter the brain through the music. So whatever is given in music is acceptable or understood by the child. So music therapy is very important. Play, dance, and yoga. Anyway, another therapy session of expressing themselves. They can do what they want. So their creativity is brought forward. Now, the challenges in the management, they are something really important. A late diagnosis, as I mentioned. We did a study some years back and found that 50% of the children are diagnosed, but not told to them. Or told to them means to the parents. 25% the diagnosis has not been made at birth because it's not that easy. You have the Hall's criteria, and 25% only have been informed. But that has changed of late because of better awareness. So a late diagnosis means a late intervention, as I mentioned earlier, and precious time is lost. Ineffective counseling. Again, doctors are not trained. They are not aware of what to say, how to say, and as I mentioned, when to say. A delayed intervention. Even if you tell them these are the things to be done, initially they are very much active and interested, but as the days go by, many of them drop the interventional programs. Inconsistent and irregular therapies. They are, as I mentioned, they are very much maybe for a month or two. I know people who have said the child needs a speech therapy. They immediately go to Mysore where they have the National Center, and then they stay there for 2 or 3 months, come back, and then do nothing. So that is not what we want. We want a consistent therapy wherever it is, where they can approach and contact easily, and doctor shopping. This is again because of all the lacunae mentioned above. Doctors say, well, there's no treatment. Well, that is a wrong statement. What we mean by say there's no treatment is no medical treatment to revert the trisomy 21. But the moment you say that, okay, modern medicine, so they immediately go after other systems of medicine. I know people who have been duped even by engineers who have claimed, all of you, I'm not mentioning the name, who claim that they can treat AIDS and mental retardation. So these are the things which delay. These are the challenges. For these challenges, you got to keep on counseling them. You have to keep on telling them, keep on being in contact with them. Now, these produce the delayed justice. Now, what is our role? Detect early, antenatal and postnatal. Start early intervention, as I mentioned, counseling and support to the parents. Treat the associated problems, all the systems that are involved. Prevent complications. You have a cardiac problem, prevent, don't wait till the pulmonary hypertension sets in and then you say, okay, nothing more to be done. Treat complications as and when it occurs, and a regular follow-up. This is very important. Even if the child appears not to have any physical ailment, keep them under follow-up so you know what is the growth and development and how things are to be done. Now the follow-up, now this is the age-wise recommendation published recently, as Dr. Shankar has mentioned. And then here, karyotyping and genetic counseling should be done at birth or the first contact. Echocardiography at birth, if it is normal, you need not do it. But then some people recommend that it can be done at 6 months, because if you have missed something, then that can be picked up then. So unless you have a cardiac problem, you don't repeat it thereafter. Thyroid function test, even if it is normal, you got to keep on doing it, because initially it may be normal, but then it can vary. A normal thyroid may become abnormal, or an abnormal thyroid may become normal for a short while. So you do it at birth, which is normally we all do it for all children, 6 months, 1 year, and thereafter yearly. After 5 years, they say, okay, maybe once in 2 years or even once in 5 years, doesn't matter. But 5-year cutoff, that is the time brain development is the maximum, and you don't create a problem with hypothyroidism in addition to a child who is already mentally challenged. CBC, complete blood count, and the peripheral blood smear. This is important because a lot of cases do have anemia, and we do get cases where there is a TAM is there, transient abnormal myelopolyposis. As I mentioned earlier, it's about 30%. So that has to be picked up. And if that is picked up, then you got to do it more frequently till you are sure that there are no complications of leukemia later on in life. So CBC yearly, if everything else is normal, because you want to correct anemia. Even normal children do have anemia, and anemia, as you all know, contribute to cognitive disability. Audiology and learning, yes, hearing at birth, OAE, you do it, but then 6 months you got to do a BERA, because you want to make sure that there is no problem. And thereafter, at 18 months to 2 years, and then yearly, because they can have, a lot of them can have eustachian catarrh, eustachian block, a middle ear effusion, and that can lead on to a hearing problem. And when there is a hearing problem, of course, the speech is already affected. And then there can be sensory neural deafness in children with Down syndrome in later period also. Ophthalmology, as I mentioned, 50% do have problem. There can be nystagmus, which has been addressed, blepharitis, strabismus, and of course, many of them by 5 to 6 years, they have a defective vision. Dental again is very important because of the malalignment of the teeth, they can get early caries, a lot of other problems because of that. Testicular examination, we all know that the testicular tumor is higher in children with Down syndrome. So from 2 years onwards, you've got to just see the size of the testicle. Growth and development, whenever you have in contact, you have to assess the growth and development. And growth, you have to chart in a Down syndrome specific growth chart. We don't have a Down syndrome specific growth chart in India, but there are ones available from the US by the CDC and UK. But our children may not be at par with those children also. It may be in the third centile. But then what is needed is a growth pattern, the growth curve, and not how much it is. But that has to be done so that you know how the child is faring. This is again one of our children who came in the papers because of he used to serve Suleimani in one of the restaurants here. And then people said they went to have the Suleimani, not to have the Suleimani alone, to see his smile. He's working on his own now in another place. He was in the Middle East, and then he has come back now. Now, the future of therapy. We have been talking about gene therapy for a long, long time. And it is still, I should say, in the developmental stage. Drugs to suppress the expression of the extra chromosome. As I mentioned, 150 to 300 chromosomes, extra chromosome. It's something like having a class of 80 and 2 children are being very naughty. So the teacher cannot take the class, neither can the other 78 people listen to what the teacher is taking. So you got to suppress the 2 people, the other children will be okay. So something similar is what they have in mind. Suppress the 300 genes or 250 to 300 genes. And then you have it because it's a duplication of the normal genes. So suppress that, and then you probably will be able to have a normal. Drugs to improve cognition. Various drugs have come in, various drugs are still in the market. The question is, do they affect cognition? Well, I'm not sure about it. Some of them say that many of the drugs are totally inefficient, and paracetamol was used for a long time, and it was that paracetamol in children was a drug in search of a disease. So that's it. Thank you, and I can answer the questions if any of you have. Thank you very much.
Thank you, sir. That wonderful, thought-provoking talk on Down syndrome. Started with a beautiful 2 case scenarios where justice denied. And I think even 10 years back in India also, people will feel that the Down syndrome children with the congenital heart disease, whether we should do the surgery. But now, definitely the concept and things has been changed after the HITM program and those things. Now, we are not considering that. As we know, for congenital heart disease or VSD, Down syndrome children has to do the surgery earlier because they will develop early pulmonary vascular disease. So
it was a problem when I started the program in 2000. There used to be a lot of, because I used to advocate surgery, and there were people who were calling for, even from Bombay, saying that the cardiac surgery is refused to do it. So what should I do?
Correct.
Now
So
it has changed, totally changed.
Totally changed. Cardiac surgery, previously it was, we cannot say refused. Probably at that time, facilities may not be that much high. So priority-wise, these children will be sidelined. Even in our setup, we know. When I was doing PG in 94, 97, only Sri Chitra is the facility is there. So now we are limited facilities are there. At that time, naturally we know that priority were not given for these Down syndrome, children with the Down syndrome, because definitely there are other problems are there. But now things are totally changed. They are totally every point of their, like ADNT problem, ophthalmology, everything has identified early and managed. So many messages are as given. I don't want to give repeated. Any questions are there that we will take first. Otherwise, I will give a message later, because I think we should give more time to discuss other people. Any other people wants to ask any questions?
I think all of them are slept.
No, they are all there.
Usually after the first person asks the questions, normally I get a bombardment of questions. It's an initial person, and so somebody has to ask the questions, and then others
Correct,
come.
that's it. So, sir, can you tell the crowd regarding that certification, that part also, because that is a practical problem. All those people will.
Now, that is very important, which is many of the doctors are not aware of it. And then they have a lot of facility given by the government. And to make use of those facilities, you got to have certain things. You got to have a medical board test, which says the percentage of disability. So that is a long process. You got to make a request for it, and then they will send a letter to you as to when to come and where to come. Usually in the medical college, or where the medical college is not there, they have the district hospital. They give a particular date, and you go there, and a panel of doctors examine it. And in previous years, what I used to see was somebody will just say, okay, then your IQ is 60, 50 madi. So that is how they used to write the IQ. But now things have changed. They have at least some tests coming to a conclusion of what the IQ is. And then you get the medical board certificate. With the medical board certificate, you go to apply for the UDID. That's a unique disability ID. Now, this is going to be as important as Aadhaar in the coming years. To get the UDID again is a long process. Many of your patients have applied, they have more than 1 year, 2 years, and they have still not got the UDID because there's a long process again. It has to be sent, the DMO has to forward it, and finally it's a central government thing which takes a long time. Now, this ID is valid, will be valid for anything hereafter. Even now, it is valid for a lot of things. Something like your concession for travel and other things. So UDID is very important. You tell them you got to take a UDID. Another aspect is regarding the after the age of 18, you got to take a legal guardianship. Because any person who completes 18 years, he becomes a major, and he or she can take her own decision. But in a child with intellectual disability, not only Down syndrome, any intellectual disability, that may not be there, and they may be taken for a ride by even relatives. So the government says that after the age of 18, somebody has to apply for legal guardianship. It can be the father, it can be the mother, or anybody. So even though the child is past 18, the mother or the father should get the legal guardianship certificate of the child. Only then, so anything can be done on their behalf. Even a bank account, even if you have a property, if you want to sell it, somebody can go to court against it because the child is eligible for that, and the child cannot consent on that. So, but a legal guardian can take a different opinion in such cases. So that again is very important. There are many people who, though have advice, they say, oh, I don't know, that is it, because people don't know the extent or the gravity of the problem. The next thing is insurance is usually denied to these children. Even though it is not a disease, many insurance companies totally deny. The moment you say the child has Down syndrome, it is denied. For that, there is a project known as Niramaya by the government. So you can register in Niramaya. The premium is very low. It's only about 300 to 500 rupees per year. And then you get reimbursement even for OP cases. So if they want to go for a physiotherapy, you go to a speech therapy, all these cases, once in 2 months, they get the signature of the doctor and send it. There are a lot of my patients who are getting benefit with this, Niramaya. So tell them this can be applied online along with your ID cards and things like that. And then it is possible. Now, these are things I think we as doctors are not very much aware of, but then we should be able to guide them as to how to make use of all the facilities given by the government. And any child going to school, whatever school it is, there's an allowance by the government for all children with intellectual disabilities, which was about 28,000 per year till last year. Now, this year, I think there has been a change. And then since what they say is since more people are applying, the same fund has been equally divided.
There were problem in schools, private schools. Sometimes they will say patients, children, they will not take. So what is the support society and Down syndrome? As a doctor, what all things can be done practically?
The school problem is they want to keep their results good. So they are afraid, 100% result may become 99%. Now, this is a problem with them. But no school can deny admission to any child with intellectual disability. Till 10 years, any child can join, at least in Kerala, into standard 1. So only about 7-8 years from first standard, they can do it pretty fast. I mean, they can pick up instead of putting the child at 5 years to first standard. If any school headmaster or a headmistress denies, ഒരൊറ്റ ലെറ്റർ എഡ്യൂക്കേഷൻ ഡിപ്പാർട്ട്മെന്റ് വിട്ടാൽ മതി, സ്ട്രിക്റ്റ് ആക്ഷൻ വിൽ ബി ടേക്കൺ. പക്ഷെ പലപ്പോഴും വിടാത്ത എന്താ കാരണം എന്ന് വെച്ച് കഴിഞ്ഞാൽ അവരോട് വഴക്കിട്ടിട്ട് പിന്നെ ആ സ്കൂളിൽ പോയി ഞാൻ ജോയിൻ ചെയ്യേണ്ട കാര്യമുണ്ടോ, നമ്മൾ ആ സ്കൂളിൽ ജോയിൻ ചെയ്യേണ്ട വേറെ പോയി ജോയിൻ ചെയ്തോ. പക്ഷെ അങ്ങനെ വിട്ടിട്ടില്ലെങ്കിൽ എനിബഡി ക്യാൻ റിഫ്യൂസ് എന്നുള്ള. ആൻഡ് മോറോവർ ദ ഗവൺമെന്റ് ഇസ് ഹാവിംഗ് പ്ലാൻസ്, നേരത്തെ ഉള്ള പ്ലാനാണ്, പക്ഷെ എല്ലാവർക്കും കൊടുക്കാൻ പറ്റില്ല. വാട്ട് ദേ ഹാവ് ഇസ് എ ഷാഡോ ടീച്ചർ. അതായത് ഒരു സ്പെഷ്യൽ ടീച്ചറെ ഓരോ സ്കൂളിലും അപ്പോയിന്റ് ചെയ്യുക, സോ ദാറ്റ് ഇങ്ങനെയുള്ള കുട്ടികൾ, ബിക്കോസ് നോർമൽ ടീച്ചേഴ്സ് മേ നോട്ട് ബി ഏബിൾ ടു ഹാൻഡിൽ ദം. They may have all said and done, they may have പഠിക്കുന്നുണ്ടെങ്കിലും they may not be at par with the other students. അപ്പൊ അങ്ങനെയുള്ളവർക്ക് സപ്പോർട്ട് ചെയ്യാനും ടീച്ചർമാർക്ക് ഒരു ഗൈഡൻസ് കൊടുക്കാനായിട്ട് സ്പെഷ്യൽ ടീച്ചർ ഒരു ഷാഡോ ടീച്ചർ. ബട്ട് ഇതിനുള്ള പ്രോബ്ലം ഗവൺമെന്റ് wanted to employ one special teacher for each school. പക്ഷേ then they found out അത്രയധികം ക്വാളിഫൈഡ് സ്പെഷ്യൽ ടീച്ചേഴ്സ് നമ്മുടെ നാട്ടിൽ ഇല്ല. അതുകൊണ്ട് one teacher was allotted to 3-4 schools. അപ്പൊ then becomes ഒരു സ്കൂളിൽ ചാടി മറ്റേ സ്കൂളിൽ പോകും. Ultimately, it did not serve its purpose. So what I suggest is you send to a normal school, talk with the class teacher or teacher first, and see that you arrange a special teacher for educating them. Because many of my children are going to normal schools. What they say is we talk with the teacher, we talk with the principal, and some of them talk to the parents of the class, of that particular class. And so that then the parents are very much cooperative. Oh, why not the Vutto? And the other children are also very much considerate and they take care of these children. പണ്ടൊക്കെ പേരൻസ് പറയാറില്ലേ, ഇങ്ങനെയുള്ള കുട്ടിയെ ക്ലാസ്സിൽ വിടുകയാണെങ്കിൽ ഞാൻ എൻ്റെ മോളെ സ്കൂളിലോട്ട് വിടത്തില്ല, ഇങ്ങനെയുള്ള മന്ദബുദ്ധിക്കാരെ ക്ലാസ്സിൽ വിടാനല്ല പഠിപ്പിക്കുന്ന lot of things. But then with the awareness that we have created, a lot of changes have taken place. 10th class പാസ്സായ കുറെ പിള്ളേരുണ്ട്. And the paper of 10th class or 12th class, it doesn't make a difference. It's you're living in a society, they're highly trainable, they can do a work. One of my students film acted, and then there are other who are models, who are calendar girls, who are computer professionals, dance teachers, they're all living on their own. So basically, how to live on your own, that is what we should give stress.
Thank you, sir. Very important points you have told. That's why nobody is asking. I thought I will ask some questions which you have not touched upon. And another thing, if anybody wants to ask anything. Okay. Then one more thing, sir, you have been saying for last so many years, so many Down syndrome children. So what are the problems of an adult Down syndrome individuals?
Yeah.
Some points.
Yeah. One is once they become a older child, they don't get a proper medical treatment, a checkup at least. So it is a duty of pediatricians to hand over these children to an adult physician who is interested in these children. Otherwise, they go to general physician. Anyway, this is a case of Down syndrome. So the child is not getting a proper follow-up from the doctor. So ideally, whatever age you are seeing, whether it's 18 years or 21 years, some of the children still come back to me. You hand it over to somebody who will take care of these children because they have a lot of problems. One is a sexuality. They have all the feelings of a normal human being, but this is totally ignored. So our buddhimanti ullarku avarku ingante vikarangalonnum illa, avarku ella vikarangalum undu. So you must understand them. Adu suppress cheyanalla, understand them, talk with them. You should know how to handle them. Psychological support is very, very needed, both as well as the sexual feelings. Why am I not being married off? അല്ലെങ്കിൽ മറ്റെന്തെങ്കിലും ജോലിക്ക് പോകുന്നു, എനിക്ക് എന്താ അതുപോലെ ഒരു ജോലി കിട്ടിയാല്, അല്ലെങ്കിൽ മേപ്പോട്ട് പഠിക്കാൻ പോകുന്നു, മെഡിസിന് പോകുന്നു, എനിക്ക് എന്താ മെഡിസിന് പോയാല്. സോ ദീസ് ആർ ആസ്പെക്ട്സ് വിച്ച് ഗോ ടു അപ്പൊ ഒരു ഡിപ്രഷൻ ഈസ് വെരി കോമൺ ഇൻ ദീസ് ചിൽഡ്രൻ. അപ്പൊ അത് നമ്മൾ മനസ്സിലാക്കണം. വി ഗോ ടു ടെൽ ദം വല്ല പ്രോബ്ലം ഉണ്ടെങ്കിൽ അതൊന്ന് ഹാൻഡിൽ ചെയ്യണം. യു ഗോ ടു ഹാവ് എ ക്ലിനിക്കൽ സൈക്കോളജിസ്റ്റിന്റെ കയ്യിൽ. പിന്നെയുള്ള അസുഖങ്ങൾ, സെൻസോറി ന്യൂറൽ ഡെഫ്നെസ് കൂടുന്നുണ്ട്, മയോപ്യ കൂടുന്നുണ്ട്. പിന്നെ ആഫ്റ്റർ എ സർട്ടൺ ഏജ് ഇഫ് ദേ ആർ നോട്ട് പ്രോപ്പർലി ടേക്കൺ കെയർ ഓഫ്, അവരങ്ങ് ഒരു അൽഷൈമേഴ്സ് എന്ന് പറയത്തില്ല, അവര് വളരെ ആക്റ്റീവായിട്ട്. എൻ്റെ ഒരു കുട്ടി കടയിൽ പോയി, സ്വന്തം ഫാദറിന്റെ കടയിൽ പോയി കാര്യങ്ങളൊക്കെ ഹെൽപ്പ് ചെയ്തുകൊണ്ടിരിക്കുന്ന കുട്ടി ഒരു 6 മാസം കൊണ്ട് കടയിൽ പോകാതെ വീട്ടിൽ തന്നെ ഇരിപ്പായി. because the child was not counseled or taken care ഇതിന് വേണ്ടിയിട്ട്. അപ്പം വലിയ ആകുമ്പോൾ പിള്ളേർക്ക് അങ്ങനത്തെ കുറേ പ്രോബ്ലംസ് ആണ് വരുന്നത്. ഇൻ അഡീഷൻ ടു ദി അതർ പ്രോബ്ലംസ്, ഫിസിക്കൽ പ്രോബ്ലംസ്, ഞാൻ പറഞ്ഞ ആൽസൈമേഴ്സ്, കാർഡിയാക് പ്രോബ്ലംസ്, റീനൽ പ്രോബ്ലംസ്. ഓൾഡ് ചിൽഡ്രൻ നൗ ഹാവിങ് ക്രോണിക് റീനൽ ഫെയിലിയർ. പണ്ടൊക്കെ ആ ഒരു പ്രോബ്ലം ഇല്ലായിരുന്നു. കാരണം എന്താ വെച്ച് കഴിഞ്ഞാൽ 10-20 വയസ്സാകുമ്പോഴത്തേക്ക് they die due to various things. Now I know people who are 65 and still working, persons with Down syndrome. 65 വയസ്സുള്ള വർക്ക് ചെയ്യുന്ന ഡൗൺ സിൻഡ്രോം ഉള്ള ആളെ അറിയാം. അപ്പൊ അങ്ങനെ ഉള്ളപ്പം they get renal failure problem because autoimmune aspects അങ്ങനെ കുറെ പ്രോബ്ലംസ് ഉണ്ട്, which many of them which we do not know. വലുതായി കഴിയുമ്പോഴത്തേക്ക് പലതും പുറത്തു വരുന്നുണ്ട്. But we got to be aware of them. What I would suggest is a proper follow-up. ആണ്ടിൽ ഒരിക്കൽ ഇവരെ ഒന്ന് കണ്ട് അറ്റ്ലീസ്റ്റ് say hi to them so that you can screen വല്ല ഹൈപ്പോതൈറോയിഡിസം ആണോ ഈ മന്ദത, അതോ വേറെ എന്തെങ്കിലും ബുദ്ധിമുട്ടുണ്ടോ എന്നുള്ള കാര്യങ്ങൾ ഒന്ന് നോക്കിക്കഴിഞ്ഞാൽ ഒബീസിറ്റി ഈസ് another മേജർ പ്രോബ്ലം. അവര് അനങ്ങത്തില്ല, ഇഷ്ടംപോലെ ഭക്ഷണം കഴിച്ചോളും, അത് കഴിഞ്ഞ് ടിവിയുടെ മുമ്പിൽ പാട്ടും കേട്ട് ഇങ്ങനെ ഇരുന്നോളും. അത് കഴിയുമ്പോൾ നടക്കാൻ വയ്യ, മന്ദതയാവുന്നു, ആ ഒരു ഫിസിക്കൽ എയിൽമെന്റ്. സോ ദാറ്റ് ഈസ് അഗൈൻ വിച്ച് യു ഗോട്ട് ടു കൗൺസിൽ ദ പേരൻസ്. ഞാനൊരു 5 years കഴിയുമ്പോൾ തന്നെ കൗൺസിൽ ചെയ്ത് തുടങ്ങും. അതുവരെ ഉള്ളത് കുട്ടി ഒന്നും ഭക്ഷണം കഴിക്കുന്നതിനുള്ള പരാതിയാണ്. ബട്ട് 5-10 years ആകുമ്പോഴത്തേക്ക്, 10 വയസ്സാകുമ്പോഴത്തേക്ക് they start eating. I tell the parents, ഭക്ഷണം കൊടുക്കുന്നത് നല്ലതാണ്. At a certain point of time you decide how much that the child wants. ആണെങ്കിൽ തന്നെ കുട്ടിയെ കൊണ്ടൊന്ന് നടത്തിക്കുക, എക്സസൈസ്. Which if they don't do it, I ask the parents to also hold the child and walk. Parents നീ നടക്കടാ, ഞാൻ നടക്കാൻ ഇല്ലെന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ അതിപ്പോ നോർമൽ കുട്ടിയായാലും it doesn't happen. So let the parents also have some exercise, and then they can really have a wonderful life. I know children who got married.
Thank you, sir. That very highly positive notes. And actually, this year in Down Syndrome Day observed in CDC, we had a wonderful activity by the children from the Gopinath Mudugat's that art center, specialty art center. So they have done wonderfully. Wonderfully, since probably they have done a professional also. Our 40 minutes our professional show കാണിക്കുന്നവരാണ്. അതുകൊണ്ട് അവരെ റിപ്പീറ്റഡ് ആയിട്ട് പഠിപ്പിച്ചിട്ടായിരിക്കും അത്ര പെർഫെക്റ്റ് ആയിട്ട് കാണിക്കുന്നത്. ഞാനും ഇതേപോലെ ചിൽഡ്രൻ വിത്ത് ഡൗൺ സിൻഡ്രോമിന്റെ ആക്ടിവിറ്റീസ് അവർ വീട്ടിലൊക്കെ പഠിച്ചിട്ടുള്ള ഡാൻസ് നോക്കും. പക്ഷെ ഇത് റിയൽ പ്രൊഫഷണൽ ആക്ടിവിറ്റി. അപ്പൊ അത് ആയിരിക്കും. പക്ഷേ ആ പ്രൊഫഷണൽ ട്രെയിനിങ്ങിന് അവർ നിന്നു കൊടുക്കുകയും അവരത് മനസ്സിലാക്കുകയും ചെയ്തു എന്നുള്ളതാണ് we have to identify. And one dance program was there, one magic show was there, which was an excellent, means വളരെ നല്ല ഒരു പെർഫെക്റ്റ് ആക്ടിവിറ്റി ആയിരുന്നു. അതുകൊണ്ട് we know that these children can have an excellent trainable ആണ്, വളരെ നന്നായിട്ട് ആക്ടിവിറ്റീസ് ചെയ്യാൻ പറ്റും, and they can do the excellent activity. So any other person?
Dance in fact makes a lot of difference because muscle tone, coordination, even intelligence, all these things play a role in when they are learning to dance.
Anybody wants to ask any question or comments are welcome.
ഒന്നുകിൽ ഒന്നും മനസ്സിലായില്ല, അല്ലെങ്കിൽ എല്ലാം അറിയാം, ചോദ്യം ചോദിക്കാറുണ്ട്.
I think shall we close, sir? Thank you.
Sir.
Anju wants to ask something. Anju, tell.
Sir, sir, thank you for that excellent class, sir, actually. But I would like to, sir, there was one, in the antenatal diagnosis, sir has mentioned one test which was not that much familiar.
NIPT.
Yes, sir.
NIPT.
Can you just, sir, elaborate
that
a few
is-
things?
That is
NIPT ആണോ അഞ്ജു? NIPT ആണോ?
അതെ sir.
Okay.
Shankar, you're telling or
Hello,
NIPT?
sir, you can tell. No problem.
Okay.
You can tell.
It's a non-invasive prenatal test where the mother's blood is being taken. What they say is the child's blood, അതിനകത്ത് കുറച്ച് DNA would cross the placenta and reach the mother's blood. But that is not a cell-free DNA. So this can be detected. Cell-free DNA can be detected in the mother's blood. അപ്പോൾ അതൊരു ഇൻവേസീവ് ടെസ്റ്റ് അല്ല. ആൻഡ് ദെൻ അത് ചെയ്ത് കഴിഞ്ഞാൽ, ബട്ട് ഇതിനകത്തുള്ള പ്രോബ്ലം ഇത്രയേ ഉള്ളൂ, ഇറ്റ് ഈസ് there can be a 1% false thing also. It is 99% result ആകത്തുള്ളൂ. ബാക്കിയുള്ളവർക്ക് ഇപ്പോൾ 85, 83, 95 ഉള്ള ടെസ്റ്റ് വരുമ്പോൾ യു ആർ ഗെറ്റിംഗ് 99%
Sensitivity.
ടെസ്റ്റ് റേറ്റ്. അപ്പം അത് ആണ്. പിന്നുള്ളത് ഇറ്റ് ഇസ് കോസ്റ്റ്ലി. It is very costly compared to the other test. It is
available?
you can afford it. It is
Yes.
available.
Yes, it is available. Because only
Sir,
thing is, it is a screening test, as sir told. It is not equivalent to CVS or amniocentesis.
Correct.
So compared to other screening tests, it is having a high sensitivity. And for Down syndrome, it is having excellent negative predictive value of 99.5%. Negative predictive value. But still it is not 100%. 99.5. So very, very rarely you may get a case where it is negative and baby have Down syndrome. So ideally, these tests should be followed by the invasive testing. So this is already expensive of around 15,000 to 20,000. So again, invasive test is expensive. So that is why, but in precious babies or where termination, they are not anyway, don't want to do any invasive testing. This test will help you to reasonably rule out a Down syndrome fetus. So it is having its own weightage is there, but every patient you cannot suggest these cases.
Yes.
And it can be done. It is done
And
by
the-
the NGS, next generation
And the thing is, you
sequence.
got to counsel them very well. They should not have a false impression that he test negative on, so my child does not have Down syndrome. We have issues not only for NIPT ബാക്കിയുള്ളതിൽ പോലും ടെസ്റ്റ് ചെയ്തിട്ട് എന്താ the probability of a Down syndrome is only 1 in 30,000 എന്നൊക്കെ വന്നു കഴിഞ്ഞിട്ട് ultimately the child was a child with Down syndrome. അപ്പൊ അവർ കിടന്ന് ബേർഡാക്കാണ് ഇത് ഇത്രയും ഇത് കംപ്ലീറ്റ് 100% കറക്റ്റാന്ന് ഞങ്ങൾ വിചാരിച്ചത്, ഞങ്ങളോട് ആരും പറഞ്ഞു തന്നില്ല, ഞങ്ങൾ ആ ഡോക്ടർക്ക് അഗെയിൻസ്റ്റ് ആയിട്ട് കേസ് കൊടുക്കാൻ പോവാണ് എന്നൊക്കെ പറഞ്ഞ് മുട്ട. കാരണം അപ്പൊ ആമിനോസെന്റീസ് ഞങ്ങൾ തയ്യാറായിരുന്നു, വൈ വാസ് ഇറ്റ് നോട്ട് ടോൾഡ് ടു അസ്. ഇതെല്ലാം കഴിയുമ്പോഴാണ് അപ്പൊ അങ്ങനെ പലതും പറയും ഡോക്ടർമാർക്ക് അഗെയിൻസ്റ്റ് ആയിട്ട്. അപ്പൊ കൗൺസിലിംഗ് ഈസ് വെരി ഇമ്പോർട്ടൻറ്റ് ഫോർ ഓൾ ദീസ് സ്ക്രീനിങ് ടെസ്റ്റ്.
Pre-test and post-test. Pre-test counseling, you should counsel regarding what are the tests, what are the expectation, what are you going to do after getting the screen positive, and what that screen positive means. Screen positive doesn't mean baby is affected with the Down syndrome. Screen positive means you are having an increased chance of having a child or fetus with Down syndrome, and you should go for an invasive test. And what is the cause of the invasive test? What are the everything should be done in the pre-test. Post-test, again, you have to tell you are having increased risk. What are the options available?
Thank you so much, sir. Thank you, sir.
I have had some parents who say, we don't intend to do a termination if it is positive. So we don't want to do it.
We don't want to. Correct.
ഞങ്ങൾ അന്നേരം ഞങ്ങൾ അക്സെപ്റ്റ് ചെയ്തോളാം. സോ ഐ സെഡ് യു ക്യാൻ ബി ആണെങ്കിൽ യു ക്യാൻ ബി പ്രിപ്പയർഡ് ടു അക്സെപ്റ്റ് എ ബേബി വിത്ത് ഡൗൺ സിൻഡ്രോം. യു ബി മെന്റലി പ്രിപ്പയർഡ്. അതൊന്നും കുഴപ്പമില്ല. അന്നേരം എന്ത് ദൈവം തരുന്നോ ഞങ്ങൾ സ്വീകരിച്ചോളാം. ഇത് ചെയ്യേണ്ട ആവശ്യമില്ല. സോ ഇറ്റ്സ് അപ് ടു ദം, ടു ദ പേഷ്യന്റ്.
സാർ പറഞ്ഞ വളരെ ഇമ്പോർട്ടന്റ് പോയിന്റ് ആണ്. ബിക്കോസ് സം പീപ്പിൾ വിൽ ഫീൽ അത് കണ്ടുപിടിച്ചാൽ നമ്മൾ ചികിത്സിച്ച് ഭേദമാക്കി കൊടുക്കുമെന്ന് വിചാരിക്കും. സോ ദാറ്റ് ആൾസോ യു ഹാവ് ടു ടെൽ. നമ്മൾ അറിഞ്ഞു കഴിഞ്ഞാൽ വാട്ട് വി ക്യാൻ ഡു, ദാറ്റ് ഇസ് acceptable for all prenatal diagnosis. We have to tell them that it is a formal decision can be taken. We will English, we will say the sentence. You can have a formal decision. That's all. And if definitely they have decided they are not going to terminate, then what is the funda in doing all these screening tests and then invasive testing and identifying it? If they are willing to continue pregnancy, do it. That's all. It is not mandatory. That's it's a cafeteria approach. The couple has to decide what to do.
Regarding
Okay.
regarding the congenital heart disease, we were having only 1 or 2 centers in Kerala doing surgery for congenital heart disease. That time, they always look for the risk and the benefit and cost effectiveness for doing surgery. So they will prioritize the cases with good outcome. Naturally, these multiple problems, they will be sidelined. Now, as the Hridyam program is rolled out, many centers are started doing the surgery. So Down syndrome patients are also getting more and more attention. And people are now coming forward and taking cases and doing. That is one thing. Even if we are doing also, there is chance of pulmonary arterial hypertension for Down syndrome patients. But they are getting more attention as compared to the previous thing. That is one thing. And we are having all these facilities for early detection. And now late pregnancy is a very common thing. And the chance, what about the incidence and detection of Down syndrome now as compared to previous years?
Well, we still have a lot of children who have not been, the antenatal screening has not been done and they come up with Down syndrome. വലിയൊരു വ്യത്യാസമുള്ളതായിട്ട് എനിക്ക് തോന്നുന്നില്ല. ഡിറ്റക്ഷൻ ഉണ്ട് ആൻഡ് ടെർമിനേഷനും നടക്കുന്നുണ്ട്. I don't have the exact numbers. Compared to previous years, we still have a lot of cases of Down syndrome in spite of educating all these screening tests, because that is not being done. In a heart disease, there are many reports, publications stating that the risk is not different compared to a normal child, because in things like VSD and ASD, it is almost same. The initial problem എന്നുള്ളതേ ഉള്ളൂ. അതിനകത്ത് വലിയ റിസ്ക് കൂടുതലായിട്ട് ഇല്ല എന്നുള്ളതാണ്. Of course, ECD
Surgical risk is not there, but the problem is they are having infection, atlantoaxial dislocation, anesthetic problems. All these things are.
അതൊക്കെ നോക്കിയിട്ട് അറ്റ്ലാന്റോആക്സിയൽ ഇത് നോക്കിയിട്ട് മാത്രമേ for any surgery, for any anesthesia and in combat sports, atlantoaxial stability should be looked by an MRI. പണ്ട് പറയുന്നത് എക്സ്റേ എടുത്താൽ മതി എന്നുള്ളതായിരുന്നു. By 5 years get an X-ray of the cervical spine done എന്നാ പണ്ട് പറഞ്ഞിരുന്നത്. But then they found children who had a normal X-ray also had quadriplegia and died, whereas the children who had an abnormal X-ray never had any problem also. അതുകൊണ്ട് ഇപ്പം routine ആയിട്ട് അത് എടുക്കാനായിട്ട് ആരും recommendation ഇല്ല. But then if you are engaged in combat sports, if you are getting any numbness, if you are getting any sensation loss, or prior to an anesthesia where the neck has to be extended, going for an AIA, atlantoaxial instability, MRI എന്നുള്ളത് പറയുന്നത്. ഇൻഫെക്ഷൻ പഴയതുപോലെ വലിയ കൂടുതലൊന്നുമില്ല. പണ്ട് they were not treated because they are more prone to infections. സംഗതി ശരിയാണ്. But we have got very good outcomes.
That is when you are having a case without that risk, so they will prioritize. Why we have to take this? That was the way. Now the things are changing because there are so many centers are doing.
That is true.
Let me give my example. When I was a medical student, ഞാൻ ഒരു മെഡിക്കൽ സ്റ്റുഡന്റ് ആണപ്പം എന്നെ പഠിപ്പിച്ച ഒരു കാര്യം ഇതാണ്. കാരണം കേസസിന് ലൈക്ക് യു ഹാവ് എ മെനിഞ്ചോ, ഡോണ്ട് അഡ്വൈസ് സർജറി. കാരണം അത് സർജറി ചെയ്താൽ the child may still be a paraplegic and the child may curse you throughout the life. So it's better that the child, because the burden of the society is not there. അതിപ്പോഴും വെസ്റ്റേൺ പറയുന്ന ഒരു കാര്യമാണ്. ഇങ്ങനെയുള്ള കുട്ടികൾ let them die എന്നുള്ളത്. But അതുകൊണ്ടാണ് WHO, United Nations Convention on Persons with Disabilities 2006 വന്ന് they have every as a normal individual. They have every right. അപ്പം inclusion in health. അതിനുശേഷം ഒരുപാട് ഇത് വന്നിരിക്കുന്നത്. Not only because prioritization, ഇതുകൊണ്ടാണ് prioritization വരുന്നത്. കാരണം because sideline because they have got Down syndrome. അവിടെയാണ് പ്രയോറിറ്റൈസേഷൻ പോകുന്നത്. ഡൗൺ സിൻഡ്രോം ഇല്ലായിരുന്നെങ്കിൽ they get a priority. അത് പാടില്ല. What they say.
There is a question
Jojo,
in that box.
Jojo has asked, is there any significance for the first trimester screening test separately other than cumulative risk?
എന്ന് വെച്ചാൽ
എനിക്ക് മനസ്സിലായത് ജോജോ ഉദ്ദേശിച്ചത് ഇതായിരിക്കണം. അതായത് നമ്മൾ യൂഷ്വലി ഫസ്റ്റ് ട്രൈമസ്റ്റർ സ്ക്രീനിങ് വി വിൽ ഡു ആസ് എ കമ്പൈൻഡ് ബയോകെമിക്കൽ ആൻഡ് അൾട്രാസൗണ്ട് ആയിട്ടാണ് ചെയ്യുന്നത്. ഇൻഡിപെൻഡന്റ് ആയിട്ട് ചെയ്യുന്നതോ അല്ലെങ്കിൽ ഓരോ മാർക്കറായിട്ട് ചെയ്യുന്നത് കൊണ്ട് ബെനിഫിറ്റ് ഉണ്ടോ എന്നായിരിക്കും ചോദിച്ചത് എന്നാണ് ഞാൻ മനസ്സിലാക്കുന്നത്.
അങ്ങനെയാണ് സാധാരണ ഇറ്റ്സ് ഒന്നിച്ച് ചെയ്യുന്നതാണ്. യു ഗെറ്റ് കമ്പൈൻഡ് ആണ്, യു ആർ ഗെറ്റിംഗ് എ ബെറ്റർ റിസൾട്ട്. ഫസ്റ്റ് ട്രൈമസ്റ്റർ സ്ക്രീനിങ് ഈസ് മോർ എഫക്റ്റീവ് ദാൻ ദ സെക്കൻഡ് ട്രൈമസ്റ്റർ. ഡൂയിങ് മൾട്ടിപ്പിൾ ടെസ്റ്റ് അതൊക്കെ ചെയ്യുന്നുണ്ടെങ്കിലും.
ജോജോ, ഡു യു വാണ്ട് ടു ആസ്ക്?
യെസ് സർ. ആക്ച്വലി ഞാൻ ഉദ്ദേശിച്ചത് എന്താ വെച്ചാല് നമുക്ക് എപ്പോഴും കിട്ടുന്ന ക്യുമുലേറ്റീവ് റിസ്ക് ആയിട്ടാണല്ലോ.
അല്ല, ക്യുമുലേറ്റീവ് എന്ന് ഉദ്ദേശിച്ചത് മൾട്ടിപ്പിൾ മാർക്കേഴ്സിന്റെ ക്യുമുലേറ്റീവ് എന്നല്ലേ ഉദ്ദേശിച്ചത്? അതായത് പാപ്പ, ബീറ്റ HCG, 4 അൾട്രാസൗണ്ട് മാർക്കേഴ്സ്.
അതെ, ഞാൻ ഉദ്ദേശിച്ചെന്ന് വെച്ചാൽ എനിക്ക് വി ഹാഡ് എ ബേബി ഹു ഹാഡ് abnormality in beta HCG alone. When the papa was normal and the cumulative risk was even as normal, and the baby came out with Down syndrome. സോ
Okay.
നമ്മൾ അങ്ങനെ ഇൻഡിവിജ്വലി നോക്കേണ്ട ആവശ്യമുണ്ടോ അത്
Okay. So actually, this individual രണ്ട് പോയിന്റ് ആണ് ഇതിനകത്ത് എനിക്ക് പറയാനുള്ളത്. ഈ ക്വസ്റ്റിനിൽ തന്നെ 2 പോയിന്റ് ഉണ്ട് ആൻസർ പറയാൻ. ഒന്ന്, you told your test becomes negative and you got a child with Down syndrome. That is quite possible because it is purely a screening test. That is a thing you have to tell in the post test counseling. That the screening negative doesn't mean your baby is safe and your baby is not having Down syndrome. Test negative means your risk of having a child with the Down syndrome is low. So as per recommendation, you don't have to go for an invasive test. There are so many situations where test is negative and baby is having Down syndrome. ഇപ്പൊ നമുക്ക് ടെസ്റ്റ് ചെയ്ത് കഴിഞ്ഞ പിന്നെ നമുക്ക് കിട്ടുന്ന ഡൗൺ സിൻഡ്രോം എല്ലാ കേസുകളിലും ടെസ്റ്റ് ചെയ്തിട്ടുണ്ട്. ചിലതിൽ നെഗറ്റീവ് ആണ്, ചിലതിൽ ഇന്റർമീഡിയറ്റ് റിസ്ക് ആണ്. അപ്പൊ അങ്ങനെ നമുക്ക് പറയാനേ പറ്റത്തില്ല ബിക്കോസ് ഇറ്റ്സ് എ സ്റ്റാറ്റിസ്റ്റിക്കൽ കാൽക്കുലേഷൻ. ബട്ട് ഇത് ചെയ്യുന്ന എന്തിനെന്ന് പറഞ്ഞാൽ ചെയ്തിട്ട് നമ്മൾ ഒരു അരിപ്പെടുത്തിട്ട് ഇൻവേസീവ് ടെസ്റ്റ് ചെയ്യുമ്പോൾ if you do as a comprehensive test in a larger population, most of the Down syndrome can be identified. So there is an impact in the community if you do in a universal way. And appo ഏത് ടെസ്റ്റ് ചെയ്താലാണ് better facility? When number of markers has increased, sensitivity will increase. ഇപ്പൊ നിങ്ങൾ ഒരു മാർക്കർ മാത്രം എടുത്താൽ അതിന് 35% സെൻസിറ്റിവിറ്റിയേ ഉള്ളൂ. 2 ബയോകെമിക്കൽ മാർക്കർ മാത്രം എടുത്താൽ 50% സെൻസിറ്റിവിറ്റിയേ ഉള്ളൂ. 2 ബയോകെമിക്കൽ മാർക്കറും ഫസ്റ്റ് ട്രൈമസ്റ്ററിലുള്ള 4 അൾട്രാസൗണ്ട് മാർക്കറും, ദാറ്റ് ഇസ് നുക്കൽ ഫോൾഡ്, നേസൽ ബോൺ, ട്രൈകസ്പിഡ് റിഗാജിറ്റേഷൻ, ടെക്ടസ് വീനോസിസ് ഫ്ലോ, ഈ 6 മാർക്കറും കൂടെ കറക്റ്റ് ടൈമിൽ ചെയ്താൽ your combined risk is having a 95% sensitivity or positive or negative predictive value. So when combined marker is there, always that has to be done. Independent marker ഒരു വാല്യൂ ഇല്ല. ബീറ്റ ICG മാത്രം കൂടി, AFP മാത്രം കുറഞ്ഞു, അല്ലെന്നുണ്ടെങ്കിൽ പാപ്പ മാത്രം കൂടി, അതിനൊക്കെ വേറെ കാര്യങ്ങളുണ്ട്. പാപ്പ is related to pregnancy induced hypertension. AFP is related to neural tube defect and congenital nephrotic syndrome and omphalocele. So many other things are related to that. Down syndrome and always combined risk.
Okay, so
That has to be
യാതൊരു കാര്യമില്ല.
independent ആയിട്ട് ഒരു കാര്യമില്ല.
ഒരു കാര്യമില്ല.
Should be done comprehensively.
സാർ ആക്ച്വലി ഞാൻ അങ്ങനെയല്ല ഉദ്ദേശിച്ചത്. ഇൻ ദിസ് കേസ് റെട്രോസ്പെക്റ്റീവ് നോക്കിയ സമയത്ത് നമ്മൾ റിസ്പോൺസിൽ കാണുന്നുള്ളൂ. അപ്പം when we just went through the result, it was seen that okay, this thing was on the abnormal side. So did we miss something എന്നുള്ളൊരു?
No, അല്ല അതാ ഞാൻ പറഞ്ഞേ. അത് നിങ്ങളൊരു ഇൻഡിപെൻഡന്റ് കേസ് ആയിട്ടാണ് നോക്കുന്നത്. നിങ്ങൾ ലാർജർ നമ്പർ കേസ് നോക്കുമ്പോൾ അങ്ങനെ കിട്ടത്തില്ല. നമ്മളിപ്പോ നിങ്ങൾ പറയുന്നത് പോലെ ബീറ്റ ICG മാത്രം കൊണ്ട് ഡൗൺ സിൻഡ്രോം കിട്ടണമെങ്കിൽ ഈ സ്റ്റഡി നേരെ തിരിച്ചാണ് ചെയ്യേണ്ടത്. അതായത് ബീറ്റ ICG കുറഞ്ഞവരിൽ എല്ലാം ഡൗൺ സിൻഡ്രോം ഉണ്ടോ, ഐസൊലേറ്റഡ് ബീറ്റ, അങ്ങനെയില്ല. That has been proved.
Okay, sir. Thank you.
Okay. So I think we had a very good discussion for last 1 hour. Over to thank you very much, sir. An excellent talk and discussion. I think most of the people have benefited by the discussion. Over to Rukmani madam and Beno.
Thank you, Dr. Shankar, and thank you, Shaji sir. And സാറ് പറഞ്ഞതുപോലെ ആർക്കും മനസ്സിലാകാഞ്ഞിട്ടല്ല ക്വസ്റ്റ്യൻസ് ഇല്ലാത്തത്. സാറ് ഒരു ഡിഫറെന്റ് ആയിട്ട് അറിയാത്ത കാര്യങ്ങളിലേക്കാണ് വെളിച്ചം വീശിയത്. സാധാരണ നമ്മൾ ഡിസ്കസ് ചെയ്യാത്ത പല പോയിന്റ്സും കവർ ചെയ്തു. സോ ഇറ്റ് വാസ് എ വെരി എൻലൈറ്റിംഗ് ടോക്ക്. സാധാരണ ഒരു ഡൗൺ സിൻഡ്രോമിന് നമ്മൾ സംസാരിക്കുന്ന പതിവ് ശൈലി മാറി എന്താണ് ചെയ്യേണ്ടത്, മുന്നിലോട്ട് എന്താണ് എന്നുള്ളതാണ് സാറ് ക്ലാസ് എടുത്തത്. സോ ഇറ്റ് വാസ് വെരി നൈസ്. താങ്ക് യു വെരി മച്ച് സർ. Now I invite Dr. Anju Kanmani to say a vote of thanks.
Thank you, madam. First of all, we all know that there are many events and many news which is coming up with the justice delayed in many issues of and on various segments of our life and all. And sir has enlightened us and as Rukmini ma'am was telling, sir has pointed the direction to that part of the actual management of children living with the trisomy 21, and that itself was we knew that, but this was another stress from sir that we should address them with the term that baby or the child living with the trisomy 21 and all. And of course, as Madam was telling, sir has enlightened us on various different aspects of management of the child with the Down syndrome, especially regarding this Niramaya and all. I don't know whether all of us are aware of, even government, the government sector also, whether they are all aware of this Niramaya and the legal protection things and all. And we know that Down syndrome, the topic is a very extensive topic, and sir has comprehensively dealt with it and has pointed out the major right things that we should stress upon. And we are more enlightened regarding the increasing the quality of life of children living with the trisomy 21, as well as the quality of the life of the caretaker who is taking care of the child and all. And as we all know, the Down syndrome, child with Down syndrome, this time the day has taken the logo, I mean the slogan as with us and not for us and all. So at this juncture, I would like to thank from my part as well as from IAP Thiruvananthapuram, Dr. Shaji Thomas sir, Chief Pediatrics at Clinical Support Services, BMH Calicut, for that enlightening and excellent presentation. Thank you so much, sir. And
Thank you.
Dr. Chandar VS sir, our dear sir, sir is additional professor of pediatrics and geneticist from SAT Hospital. Sir was always there with the various classes and enlightening us on the importance of the genetics and taking classes in that. Thank you, sir, for chairing this session. And I would also like to thank the other participants who have taken part in this interesting session of academic discussion. And I would also like to thank the President, Dr. Rukmini Madam, District President IAP, and Benno, District Secretary IAP. And once again, thanking all the participants who have taken part in this excellent discussion and wishing all a great time ahead. It is thank you and good night from all of us. Thank you, ma'am.
Let us disperse the meeting. Thank you all. Good night.
Good night, Shaji sir.
Yeah, good night, Shankar. Good night to all of you.
You too.